December 20th, special meeting of council. Approval of the agenda. Councilor Nobury.
That the Tuesday, December 20th, 2022 special council meeting agenda be adopted as presented.
Seconder. Councilor Julik. All in favor? Carried. We're just waiting to add people by Zoom here.
Melanie and Angela, can you hear us?
Yes, now I can.
Okay, so delegations, we have Melanie Maracle, Health Service Administrator for Chetwynd and Tumbler Ridge. Dr. Iffy is supposed to join with Chief of Staff, and Angela DeSmit, Chief Operating Officer, to present on Northern Health's update to Council.
Well, thank you for having us, and I would just like to welcome, all the new members to your council and your worship as well. Congratulations on becoming the mayor of Tumbler Ridge, and we're pleased to have this meeting. Typically, we try to meet with the mayor and council. I think it's about quarterly at the regular meetings, or also at the call of the mayor and council, and just to provide an overview of the health services and the great successes we're having, as well as some of the challenges. So I'm going to hand this over to Melanie. Melanie Maracle is the Health Services Administrator for Tumbler Ridge and Chetwynd, and soon we'll also be capturing Hudson Hope in the new year, just because of the great alignment that's been happening between the corridor, the three communities, and Melanie has presented or prepared a presentation. So sorry, I should introduce myself. I am Angela DeSmit. I'm the Northeast Chief Operating Officer for Northern Health. I reside in Fort St. John and on the traditional territory of Treaty 8 First Nations. I moved out to this area in 1976 with my parents, and they still live north of Fort St. John. And I went away for a few years, but came back and have been here and working and enjoying the communities ever since. So thank you.
Thank you, Angela. I'm Melanie Maracle, and as already mentioned, Health Service Administrator for Chetwynd, Tumbler Ridge, and soon to be Hudson's Hope. I live, work, and play on the Treaty 8 First Nations as well. I now live in Chetwynd and partner very well with our First Nations communities of Soto and West Moberly. I wanted to ask Mayor and Council, and by the way, congratulations to everyone. Were you presented a copy of this PowerPoint presentation ahead of time?
Yes, we are.
Awesome, wonderful. So, Mayor, would you like me to go straight into it, or were there any introductions or words you would like to say before I go into the presentation?
No, the floor is yours, and Dr. Iffy has joined the delegation as well in Town Hall.
Wonderful, thank you. So we presented almost a year ago to previous mayor and council, and so this is an updated presentation deck of what has happened in the past 11 months. The last time we presented in January of 2022. So if we move to the first slide, I wanted to talk about some of our successes in the community. We do currently have 3 general practitioners in the community. In addition to that, we also have a part-time GP that will be starting in the new year. And predominantly, I believe the plan is there that the part-time GP will be able to fill kind of those locum holes when any of the other physicians go on vacation, so that we have adequate coverage. We're also have been very successful in recruiting and maintaining physicians in the full complement for a number of years. And I think that's a testament to the lovely community of Chetwynd. Becky Borton, who used to be a practice support coach with Northern Health, she is still with us, but has moved into a different role. She now, over the past I think I'm correct, in around 10 months has been a psychological health and safety advisor for the Northeast. But prior to changing roles, she had been working with Lisa Johnson, our primary care coordinator, in trying to increase the flow and efficiencies for same-day appointments and appointments in the clinic in general. When physicians are within the community, we are generally able to see people within 1 to 2 weeks, but when physicians leave the community, that has left a hole where during those time frames, the appointment times increase. And I will talk about the appointments a little bit later, also within challenges. We also now have and have been continuing to try and advocate within all communities that we do have Northern Health's virtual support clinic. And this is something that runs 7 days a week from 10 a.m. to 10 p.m. So the unique ability of the virtual health clinic is allowing people, if, for example, they need their prescriptions refilled, instead of trying to make an appointment to see their GP, who might have a 1 or 2 week time frame, they could utilize the virtual health and be able to get that done over the phone from the comfort of their couch. We continue to try and work in the clinic space that we have to redesign it in a way that creates efficiencies. And one of those things that we have done and has been in place for a number of years, but we continue to see it as a success, is our interprofessional team space. And that's sort of our outpatient clinic that we have when you, that sort of sits in that main hallway as you're walking to registration. This alleviates us having to use things like IV therapies within the emerge rooms, and we can continue to dedicate those rooms to emergency patients. And then we have planned scheduled outpatients through the IPT space. And so we have really found that has been very successful in allowing timely access to some of these ongoing care that people might need. Angela, did you want to add anything?
Just in terms of, in case though you're not quite sure what IPT means, so that's interprofessional team. So that's where staff that are either nurses or the social worker can use those space for providing more community services within the center.
Thank you, Angela, for that. Challenges that we've recently started to see is a significant increase in Conuma staff trying to make appointments for sick notes. We see this actually both in Chetwynd and Tumbler Ridge. So I've been working very closely with Conuma and their leadership team in trying to come up with a solution that works, because the increase in the sick notes takes away from people who want to come see the physician for health-related needs. And so in part of this work, I just became aware yesterday when I was talking to Derek Sauve, VP of HR, that they will be making a policy change in the new year with respect to their sick notes, that we hope to see a significant change, allowing us to hopefully reduce the wait times that we've started to see increase because of the sick notes. If we want to move to the next slide, for recruitment, this is really, I think, a very positive part of Tumbler Ridge and the support that we get. We're really building a solid team. With the team that we have, we've been able to successfully recruit Lily Altsizer. She is one of the RNs that works within and lives within the community, who is going to be covering Andrea Amati as the clinical practice lead while she's away on her maternity leave. Lily has already started in the role, and so we'll have a good month overlap between the two of them to make sure that we have appropriate handover. We've also been recently using the travel resource pool, which is a Northern Health invention. It's really been very helpful for our community, where we have staff who want to work in different communities. And so we have 2 nurses that regularly come to the community through the travel resource pool. And that helps fill the void. And because they regularly come back, they really are part of the team, which really ensures good patient handover and knowledge, because they are in the community usually once every other month or so, sometimes more frequently. We've also been able to successfully hire in July or June, Valerie DeWeese, who is an RN. She is currently also taking a line, so that is good. And we've also recently hired a new grad nurse from out of community. And her husband works now in Tumbler Ridge, and so she's taken on a casual line, and we're training her on the emergency department side of things because she is not emergency trained. And when we also have a travel resource nurse, Lexi, has decided to actually convert into a casual line and work as well. So we, while we do have vacant lines, we do have a lot of casuals now that help fill the void. And the travel resource pool, we continue to also hire back through agency, many nurses that have been to the community, many, many times over the past 2 years that I've been in the role. And so, the Tumbler Ridge, I think, is a success story. We're doing very well. We have also been able to recruit a CLXT. That designation is a specially trained individual who can both do lab and X-ray. So she's been filling a relief line that we had while Jillian went to do a relief in Dawson. Jillian, X-ray tech, will be returning January 9th. But we will continue to use the CLXT within the lab to cover lab services. We also were able to successfully hire a new grad into the vacant 0.5 FTE X-ray line. She started in September, and she's been doing very well as well. So vacancy-wise, we only have some RN lines, but again, with the travel resource and our casuals and the agency that regularly return, I think in the past year we've had in total, and this is a rough estimate, but maybe 5 diversions, and many of those diversions were because of sick calls, not because of lack of staff. Are there any questions at this point, or should I just finish the presentation and we'll have questions answered after?
I think we'll just continue on with the presentation and we'll do the questions at the end.
Okay, wonderful. So on the next slide, we have challenges. We continue to have after hours challenges with BCEHS. They have a new model of service, which results in them only being called back on evenings and overnight if it is a red transfer. And so yellows will stay in community until the morning. But because our staff are on call, they have generally worked the day shift, then stay overnight for the entire shift until the crew coming on in the morning will take the individual out of town, then leaving us without that nurse for that day shift. So we are continuing to work with our partners to figure out how best to service the community. Again, I mentioned before, that we have been successful in recruiting a casual RN as well as Val DeWeese into a full-time line. However, both of those RNs did not come with ER experience. And because of the vast differences in the types of calls we can receive, we've been actively working to try and train those individuals to get the knowledge they need to cover the emergency department. Our respiratory therapist position continues to remain vacant. We've been trying to fill that since April of 2021 and have not been successful at this point. Another challenge is our social worker in the community has made a decision to move from a 1.0 full-time FTE to a 0.5. We have posted another full-time FTE social worker for either Tumbler or Chetwynd, and we're actively working to try and recruit to that role. And we still have a vacancy in home support. We are currently doing some home support redesign, which may change the FTE that we have in the community when it comes to home support. Next slide. Some successes when it comes to community services. We have now had for a year an occupational therapist in the position. In Tumbler Ridge, she also supports Chetwynd. She typically sees, this was last year's figures, and I didn't get the updated information until today, that she typically sees roughly around 30 clients a week. However, her role has now expanded in the community. So she does what we call RI assessments. Angela, I'm not very good at explaining what that stands for. Would you mind jumping in?
For sure. So whenever either a physician refers a client, or they can be a self-referral or a referral from another member of the IPT or the interprofessional team, where they feel that an individual in the community requires health services, then we complete what's called a RI assessment. So it's a resident assessment index, and it looks at things like, are they able to dress themselves? Are they able to prepare meals? Do they have healthcare needs in terms of mobilization or bathing or skin care, those types of things? And then depending on what the assessment comes out to, it then informs us in terms of how much care. So is it, you know, an hour every 2 weeks, or is it 4 hours a day, and what type of service that is? And so it's conducted by a range of healthcare providers.
Thank you, Angela. She also does case management, and then she also does the OT services. So her role is quite broad, but she's really bringing a much needed support to the community of Tumbler Ridge. Additionally to that, we continue to collaborate with our BCHS partners in our multidisciplinary weekly meeting. So if the community paramedic notices changes in the people that they're checking up on, they will then communicate that with our staff at the clinic so that we can ensure that we're monitoring those people appropriately. And the staff continue to have positive feedback on the ability to utilize our real-time virtual support, which is an iPad that they have in the emergency department where they can contact various specialists. So for a rural remote clinician, this is an added bonus. The way I've heard it described by physicians, it's like having a second doctor in the room for you to help provide guidance or troubleshoot. Next slide, just wanted to continue to advocate for the COVID-19 shots as well as the flu clinics. We continue to run them once a week. They're booked appointments at the health center. The pharmacy in Tumbler Ridge is also doing both of those, and we continue to utilize community immunizers to help in this work, and that's been very successful as well. On the next slide, wanted to talk about nursing and physician hours. So we do have our after hours being considered. How do we utilize after hours or walk-ins in particular because of the challenges with BCEHS? And so that's something we continue to do. And we also want to be mindful and considerate on the work-life balance for both our physicians, our nurses, as well as our lab and DI techs who are on call, but have generally also worked the day and work 5 days a week. And so the data here that I'm sharing on this particular slide is the data up till August 10th of 2021. So it would have been the data I provided in January of this year, where we were showing a decrease in visits at that time. And then I would like to, in the next slides, show how we are now trending based on the information. So if we turn to our what I've titled new data as of January 1st, 2021 through to October 31st, 2022, you will note by the color coding that visits are increasing overall generally, and during the day slightly on the on-call. If we turn to the next slide, I thought it would be interesting to share our time of registration when people are coming into the emergency department. And you'll note that most of the patients who are presenting over this time frame are presenting between 7 a.m. and 10 p.m. But our highest peaks are during our operational hours of 9 to sort of 4 or 5 o'clock. On the next slide, I wanted to note that this is 22 months worth of data. But again, I wanted to show what our average visit per day of the week is to help understand how the clinic is being utilized. We have on average over 22 months, 4 visits per day, Saturday and Sunday, but we are double that for most of the week when we're open. The next slide I wanted to talk about, because I think this is interesting data, is the Canadian Triage and Acuity Scale. And this is a standard that is used by our nurses to help assess a patient when they come in. And so the assessment allows, through the triaging of patients, to decide what their acuity, risk, and care needs might be based on the signs and symptoms that they're showing. And then this allows the emergency department to triage those who are have the highest risk or are the sickest first. And so that's what it's utilized for. And so CTAS-1 is, the sickest of the sick, the really imminent risk. And then CTAS-5, you'll note, is non-urgent. Angela, would you like to add anything to that at all?
Sorry, just getting off mute. No, I think it's just in terms of just understanding how we assess patients. Sometimes patients will say, well, I've been here for a half an hour and how come Mrs. Smith got in before I did? Those types of things. And so this is just in terms of they may not be visible in terms of physical or psychological health concerns that elevate them in the scale, and that's how we score it to make sure that it's seeing the person who needs to be seen first as the most critical.
Thank you, Angela. So if we turn the page, this data here that I'm showing is the after-hour visits by CTAS score. And this, I want to note, is from January of this year, January 1st till October 31st of this year, so a 10-month period. And so you'll note that during this time frame, after hours for us is from 5 p.m. until 9 a.m. the following morning. you'll note that in this 10-month period, we only saw 2 critical patients in the CTAS-1 category in the whole 10-month. We saw 75 people in the level 2, which over that 10-month period, I just did some rough averages, is 7.5 patients per month, or an average of 0.25 per day. CTAS-3, we had seen 129 people, and so that's an average of 12.9 per month, or 0.43 per day after hours. CTAS-4 is 128, so the exact same numbers as I described for level 3, and we saw 20 patients who are the non-acute CTAS-5. That's an average of 2 per month, or 0.07 per day. So we sort of see the peak for us is in the CTAS-3s and 4s, which I don't think is uncommon for emergency departments. Andrea or Angela, anything that you want to add with this data from your perspective?
No, I'm just wondering if Dr. Iffy might have something from actually working in the emergency department, whether you have any comments that you would like to share at this time.
Of what we experienced down there. So I think it's very, very accurate. Thank you.
Okay, thank you, Dr. Iffy.
Thank you. Last slide is just reflection and review. And so this is, I said outstanding work, but I should call it ongoing work. We continue to work on our home support redesign. And so looking at what the community's service needs are for the home support. Also looking at, should we have extended hours for that home support? And continue to look at OT and PT services. I think I missed a bullet earlier on. We were successful in October hiring a brand new graduate physical therapist, a PT. She's working in Chetwynd currently. My understanding from my discussions with her is that in school they spend a lot of time on inpatient home support training, but not as much of community work. So we did support her to work with the community physiotherapists in Prince George so that she could have some mentorship through them. And so she's now starting her journey in supporting the community in Chetwynd. And as she becomes more experienced, we will expand the scope to also include Tumbler Ridge. However, we do have an opportunity to have referrals, and if people from Chetwynd or Tumbler Ridge require physiotherapy, for the time being, we could have travel for them to come to Chetwynd Hospital for PT services. And so that's a real good win for us. She is local and from the community, born and raised. And so really that's the new approach that I think we need to use in the North is, invigorate people wanting to work in healthcare who are from our communities so that as we've been able to show here, we can successfully recruit back into the communities. And so that is the outstanding work that we're doing. And with that, I open it up to any questions or even to Dr. Iffy or Angela, I guess, maybe with any final thoughts that they may have of this year in review.
Okay, I just wanted to add that. Thanks a lot, Melanie, for this presentation. I think the last point she made was a very good one, trying to raise people in the community, train them to work here. I think it's better. It's going to keep, we are having a lot of, attrition rates and all that. I think that way is going to help a lot, people who live here. For example, the most recent nurse that she mentioned that we are hoping that we casual right now. The good thing about her is that she moved into the community. She lives here. So, and then we are hoping that she will eventually get working. So people like that are likely to stay longer than, you know what I mean, right? Someone who from somewhere else or another. So I hope that we are more successful in that direction. Thank you very much.
All right, well, thank you very much for your delegation and the update from the Northern Hull side. We'll do questions from council. Council Norbury.
Thank you. Thank you, Mayor Kukalka. Thank you, Melanie and Angela, for coming in to chat with us today. I did have a few questions. I'll throw them at you one at a time, though. The first one I want to throw at you is kind of maybe it's a bit of a gossipy question, but it's a concern that I've heard around the community. Maybe you can confirm or deny. I've heard rumors that one GP may be leaving in the next 6 months. Do you know anything about that? Is that happening, or is there a replacement plan in place for that?
Did you want to speak to that, Angela, or?
Well, I'm just wondering whether Dr. Iffy, as the chief of staff, and more kind of in the insight in terms of medical manpower, it is one of the reasons why we've now increased the number of medical staff in Tumbler Ridge and added another part-time position, because that's based on the interest of the physician that is interested in coming to Tumbler Ridge. But Dr. Iffy, do you have anything more to add to that?
Yes, I think I'm going to add to that. Yes, we have one of the doctors is about to leave sometime in March, but there's a good plan on ground. We've hired a new doctor already who should be starting in September. But before he starts in September, just like she mentioned, we already have a part-time, someone who is going to come in and fill that space. So we are not going to have any problems with the doctor who is leaving. There's already someone who has been hired, supposed to start in September. I spoke to him I think 2 weeks ago. It's certain, right? But we have someone in the meantime who is going to cover that space until then. Yeah, thanks.
Follow up, Council Norbury.
That's that question. I'll let somebody else have a turn.
Councillor Julik.
Hi, and thanks again for joining us today. And I'm glad you were able to not have to travel. That we've gotten used to this invention of Zoom. I wanted to refer back to the difficulty in filling some of the positions. Are you finding that it's difficult with housing, or is it just bodies? Because I know Tumbler Ridge and Chetwynd both have housing challenges as well. So I'm going to guess that it's probably both, but I'm just going to ask the question.
Currently, the last people that we were interviewing for positions, it wasn't due to housing. It was due to what I would term many options out there for healthcare providers. And so they really are picking and choosing what works for them. Sometimes we're successful, like Val DeWeese actually came to the community because of the housing options and the cost of living, in the sense that they were able to get themselves a house. So, I think sometimes, yes, there's not as much selection, but even if there isn't, people are, interested in the community of Tumbler Ridge.
Councilor Norbury.
Thank you, Mayor Kukalka. So in your presentation, your last slide, you were kind of curious about extended hours and after hours. And I know one of the concerns we do get from residents is emergencies don't always happen between 9 to 5, Monday to Friday, and people are really looking for that after-hour services, because that's when we're all out having a good time and hurting ourselves. I had some questions about your data that you provided. Maybe you can expand on them a little more. Firstly, the after-hours visits by CTAS. It seems like there's a bit of a rising amount of level 2 and level 3 people coming into the clinic in after hours. Is there anything specific that you're seeing, like, oh, these are sledding accidents, or, yeah, I'm just kind of curious if you know what those are, and maybe we can look at a prescription plan to address those issues.
I would have to turn it over to Dr. Iffy and see if he can anecdotally provide, because mine's just the raw data.
Okay, thank you for that. Not this, just more. I will just put it this way: is we cannot really tell the nature of illness that people present with, but maybe things like asthma exacerbation, injury from maybe from a motor vehicle accident and things like that. Those things are a little more serious, right? But so those are the nature of cases, and some of them also. These are cases where we have to refer. We are restricted in what we can do here. Right. For example, we don't keep patients overnight. If sometimes people just come in, it's not as severe if the case is so severe, but we need to monitor them, and we can monitor them here because we close. We don't keep patients overnight. So patients like that would need to be referred to Dawson Creek or things like that. Secondly, also, sometime in the beginning of this year, just like Melanie mentioned, we've also had some challenges with some of the staff. There was a time our lab guy was down. So we've had cases where a patient will come in here. The only reason why we have to send the patient outside is because there was no X-ray. Not because it's not that we couldn't handle the problem here, but because we didn't have X-ray or maybe the lab wasn't available on that day, right? So not really anything special, but the same routine, more severe conditions and all that.
Councillor Hoffman.
Thank you. And thank you for the packet. I really do appreciate lots of detailed info and the graphs, which is where I'm going to. Sort of an extension of the emergency care question, noticing that roughly double falls within our actual operation hours. Is a bunch of that possibly because the clinic doesn't have same-day support? Like, are people going to emergency because they can't see the doctor? Or is this just how things are, that day-to-day more injuries or more issues are happening than after hours?
Okay, let me answer that. Partly it was because of that. And then secondly, also, we are also working on educating. Sometimes we are looking for other ways to educate the community, right? Some people don't also get it right. For example, someone coming to the ER for maybe medication refill, right? For example, I think the last guy who came to the ER for medication refill, according to him, I think he works in Kunuma, and I can't remember his shift. So he can't, he's only free in the evenings. So somehow he just discovered that day that he needed to refill his medication, and he just rushed down to the ER. So some of them, yes, but most of them not really. I think we are actually working on a way of educating the community on the proper use of the ER. Yeah, because sometimes people come in there for different reasons. So, yeah.
And I appreciate that. Thank you, Dr. Iffy. To mention, Councillor, is it Hoffman? I hope I heard it right. You heard it right. Okay, I see nods. So I thank you for the question. I think we try very hard to have same-day appointments. Sometimes what we will also do, and perhaps Dr. Iffy can talk about this, but sometimes we'll have the physicians who are covering the on-call for the emergency department also take some same-day appointments if the emerge isn't busy, so that we can try and keep people in primary care instead of emerge. And so I think we try various options to try and ensure that the people coming to emerge truly need the emerge in consultation with the education of what emerge is for.
Yes, okay, to add to that, there have been cases where I think I like the way our nurses are actually doing it sometimes as well. We've had cases where patients came to the ER and the nurses in the process of triage and discovered that, this thing is not so serious, anyway. Just, they will bring the patient to the clinic, we'll see the patient that same day. We've had a lot of cases that way. Sometimes the patients are not happy, but I came to the ER. But the nurses say, we can treat this in the clinic, and they'll bring the patient over and we'll address that there. So I think some of them, like I said, actually, yes, maybe they don't have the appointment. And then also, we also do a lot of things. For example, anyone who is on call on a particular day, the next morning, they have the next morning off because maybe the night was rough or something like that. Most of us, those off days, we actually come in. so that we can address some of the maybe follow-up ER. Some of the people we saw in the ER, we asked them to come back because there might be something we need to follow up on, right? So we ask them to come back and things like that. So we try other options as well. And then we have the primary health care. For example, anyone who, after a seizure, we normally ask them to come back in a week's time to have the seizure removed. Before now, they used to come to the clinic, but we now have the primary health care where they can just go over and the nurses can get it removed. We're looking for different opportunities to make sure that we reduce the wait time and then so that they can actually feel better.
Yeah, and I think the other thing is that most of, when you think about what we do, is typically weekdays. So workers at work, kids at school that may fall off the playground and hurt their arm or those types of things. And so there is the potential to have more emerge visits during the daytime just because there's more urgent or emergent care that's required in the community of Tumbler Ridge. People are driving more, getting to and from work, those types of things as well.
Okay. Councillor Julik.
Hi, I'd just like to go back to the hours of work. So I'm thinking, and you talk about the work-life balance, and I think that that's really important. And so you talked about staff being on call, and so I guess what my question would be is, so you have some staff that are probably the only staff, like if it's a lab worker, and you can correct me if I'm wrong, so they work the day shift or they work for the day and then they're still on call. So what I'm understanding then is that this person is basically working 24/7, 365?
Yes and no. So no, great question. Really appreciate that. So yes, we have only one medical lab tech. However, we have successfully recruited in our training the CLXT, which I talked about, is that specialized position where you can do lab and X-ray. So we're now in that positive environment in Tumbler Ridge where we have sort of backup now available that I think will help for that work-life balance. And then what we have done is we've made the X-ray positions to half-time positions to again alleviate that 365 days a year, 24/7, because we heard from staff that was unsustainable. And so we're working the best we can to create recruitment and retention through making work-life balance changes for the staff.
To add to that also, sometimes as physicians, when we see a case, for example, maybe I saw a case in the midnight and it's not too severe, but I need to do an X-ray, because the truth is that not all imaging or not all tests are necessary, but sometimes we actually do them because of legal reasons. You never know. I saw a girl in Dawson Creek 2 days ago. She was dancing and all of a sudden she came in, she was on her ankle, or she said she was complaining of she can't bear weight. I almost asked her to go home, but somehow the nurse who saw her before me did an X-ray. So I just said, let me just check the X-ray before I send her home. I went there, she had a fracture. So when something very light comes in, now it looks as if there's no need to bother. Sometimes rather than call the X-ray person who has been on all day or call the lab guy, if I think it's mild, I can actually ask the patient to come back the next morning. That way, we don't want a situation where we use the lab or use the X-ray and then the next day they can't come to work, which happens a lot in other places, Fort St. John and Tumbler. So we as physicians will try to work with them to make sure that we use them efficiently rather than burn them out and then,
So, just to follow up. So I know in education that you are what is the word? You get the money from the government based on the people in your community and all of that kind of stuff. And so I'm guessing it's probably like that in health as well. And so, is this part of the problem or part of the challenge in getting people to work? 2 half-time positions sounds good for Northern Health, but I don't know that that's good for that staff member unless that's what they're looking for. Are you finding that that's happening more and more? or is it a challenge on top of that? Because I understand, it sounds like Dr. Iffy's doing some really great stuff, or that the clinic's doing great stuff getting them the next morning. But when you're on call, you're on call. Like, I've been on call and it's not, you're still on, right? Like, you can't go have the drink if that's what you want to do. You can't leave town because you're on call, that kind of stuff. And so I don't know what the solution to that is. I just wonder how big of an issue that comes with the recruitment and retention of staff.
Again, other great question. My humble perspective is, and I'm not the one who's working in the position, but when I do talk to staff, my perspective is that we live in a region that has a lot of opportunities. So some of the staff, if what they're looking for is more than 0.5, they pick up shifts at other facilities to help kind of make that more of a full-time position. And then there are people out there that actually really enjoy the 0.5. And so I would say that it's one of both of those currently for the two people in the position currently. So it actually works out really well. And then the staff also tend to cover each other off for vacations as well. So they will, be full-time for a number of weeks, a couple times a year as well. But then also, because having that 2.5s, they're able to take their vacation. And so that's really important for people's mental and physical well-being, to be able to enjoy time away from work to reset. And so I always like to look at the glass half full.
Okay. Councillor Klitgash.
Yes, I'm wondering about the travel resource pool, and how many times have we used that here in Tumbler Ridge this year?
So just to note, there's two different distinctions. So Northern Health, due to the fact that we continue to use a lot of agency staff, have created our own travel resource pool. So they're Northern Health employees. They get the same benefits. They get the same, vacation, sick time. They're paid the same as other staff that come, but we provide housing and a per diem for their meals when they're out of community. And that allows, what we have found is that pool is growing significantly, because it allows our employees who are interested in traveling or doing something different to still stay within Northern Health and work in a couple different communities. And then a lot of times after a year or so, they come back, they go to the community that they most enjoy, as compared to agency staff, which is a variety of private companies, that there is a necessary evil to agencies in terms of, particularly in rural and remote, that without them, we would have to reduce services in a number of our facilities, which include Tumbler Ridge. Same with Chetwynd. Chetwynd uses quite a number of agency staff, and Dawson Creek and Fort St. John. But the creation now of the travel resource pool means that they're part of our team and we can support them. And now the province has been picking up on this new program that Northern Health has started, and is looking to say, how do we spread this now across the province, because of the success in the retention and the growing of it, as compared to just hiring an itinerant nurse who just comes to the community once for 4 shifts or 2 weeks, and then they're gone and you never see them again.
So you don't pay the $5,000 bonus or whatever it is to these nurses that you're pulling out of your own area?
No, we don't.
Okay.
Yeah.
And
The only benefit is that sometimes we will pay for their nursing registration. But now within the collective agreement, I think they're up to 100% being paid by the union for their, which is just over $600 a year. So we do have some recruitment incentives, like critical care. they're in the larger communities, but they can't have been a former employee of Northern Health for at least 2 years before they are offered those incentives.
Follow up, Councillor Kakash.
So, one of the other things that I'd like to bring up is home care. And I know home care has always been a problem in this town. And we do all these surveys, living in at home and aged people living at home and so forth in this community. But I don't see any change in the home care over the last 3 or 4 years. You know, it seems that you're always short a person. The person's outside texting in their vehicle. They go in and talk to the person for 10 minutes, and then they're back out in their vehicle and they're texting again, and then they go. And they're not using their time the way they should. And I think they need more supervision out in the field.
So thank you for those comments. So Northern Health, prior to COVID, started on a home support redesign that Melanie briefly touched on in the presentation, where we are looking to have extended or expanded hours in all communities. And it's based on what the community needs. So in Tumbler Ridge, it may be a 6-day service or a 7-day service, and it might be till 5 or 6 at night, or it might be longer. And so Melanie is now working through that process in terms of, you know, based on the different assessments that we've done, knowing the population in the community, how do we support individuals to stay in their home for as long as they want to? And so that is coming in terms of that increase in services. In terms of individual staff texting, some of it is we have safety plans, because as you know, these staff are going into homes by themselves. And so they have to check in before they go into a residence to say, I'm now at this residence, I'm going in to see Mrs. Smith. When they come out of the facility, they also have to do a safety check for their own personal safety in case there is something happening, because they are working by themselves. So whether that's the reason why they're texting or they're checking in, or somebody from work has said, oh, by the way, we got a call from Mrs. So-and-so and she has no food in her fridge. Can you go over and check in on her? Those types of things. It is a tool for communication with the between the team members, but we can definitely follow up on that.
So why are they dispatched from Fort St. John or Dawson Creek?
So they used to be out of a central home support office in Dawson Creek. And Melanie, I believe we've changed that over now so that they're no longer being dispatched out of that central office. Melanie?
My understanding was that the scheduling is still being done by the central office, but that the staff are dedicated to their regions. So it's not like we're having staff from Fort St. John driving down to Tumbler Ridge. Was that your question, Councillor?
No. Why is it being dispatched from there? Why are the local people being dispatched from there? Why aren't they being dispatched from the local clinic here?
Yeah, we can definitely look into that. We have been slowly shifting the scheduling out to the community that knows the community better. The system that we work in schedules clients, and then it picks up whether or not they have to pay for some of their services. It depends on their income and a number of factors, and then we pair up staff in order to work with them. We have seen some good success, like Fort Nelson, who is now, like you said, scheduling their own staff because they know the community better, what would work best in terms of where to go in their community in a sequence for care. and I believe that it has been considered for both Tumbler Ridge and Chetwynd to make it more community specific.
Councilor Norbury?
Thank you, Mayor Kukalka. So I have a comment and a question/request for you. You spoke about BCEHS a little earlier in your presentation, and I just want to update you on like our efforts. We definitely are aware of BCEHS's importance in healthcare needs in Tumbler Ridge, and we are in the process of advocating to the Ministry of Health to increase the level of service there. So just wanted to throw that out there for you. My question/request is about mental health support. Are there any plans on adding a part-time or any sort of in-person mental health support in our community? I do realize that the social worker that we currently have does fill the role a little bit there, but previous to our current social worker, I believe there was a mental health support person in the facility at some point in time. So maybe you can comment on mental health support, where we're going, where we're at.
I'll ask Angela to step in if I don't describe this appropriately, but my understanding was that previously, a number of years back, there was a contract through the MDFD or something like that, where there was someone in Tumbler Ridge who did those services, but it was contracted through Northern Health. And so that person left. I don't know, maybe Angela, I don't think I'm describing this right.
Yeah, so that's for child and youth. Northern Health is not responsible for mental health for child and youth. That's the responsibility of MCFD, the Ministry of Children and Family Services, or department. And like Melanie said, in the past, we did happen to have a number of mental health clinicians in the community, so MCFD contracted to Northern Health to provide those services. But when one of the mental health clinicians left, then we weren't able to provide that, and so it reverted back to MCFD's responsibility. There is increasing conversations, I think it's happening tomorrow or so, with MCFD, because there is a mental health private counselor in the community that's interested in providing some of those services. And so Northern Health is trying to link MCFD up with those services so that they may be able to fund for that to happen. Adults, though, adult mental health and substance use is the responsibility of Northern Health. And so we do have social workers are able to work both as social workers as well as in mental health and substance use. So they can, do the social part in terms of filling out forms and applying for income assistance or housing assistance or a number of those services. But at the same time, they can also be offering mental health services in terms of assessments and providing some services related to either mental health conditions, schizophrenia, or depression and anxiety. And I don't know if Dr. Iffy has anything to add in terms of the mental health services.
Okay, yeah, so thanks for that. Mental health has always been a challenge. So, but I think we even had a discussion on last Thursday on this, really exploring various ways of addressing that. Now, number one is that we now have a plan. Just like you said, we have a social worker, and the demands are increasing. Not just here, it's everywhere, right? So, but we have a plan on ground now. We try to, first of all, whenever we have cases, we try to educate the patient, because most employers have what we call the EFAP. Most employers have their own services online or something like that, right? So we actually discovered that most of these patients who are coming in are not aware of that. So whenever they come in, we start with that. We try to educate them that, find out from your employers. We've been successful in, making a lot of them call the HR to find out about whatever services they have, and it has helped in some cases. And then the very difficult ones will now, track down to, will now refer to our social worker. Then there's something else that we've also agreed on doing for us physicians. You know, if we go by the books, any mental health case, what the physician normally does is that we see them very often. That's what we do. We see them very often, frequent visits, and then if that doesn't help, then they can actually go further. So that's what we're actually doing right now. So we also do some counseling, we do some follow-up a couple of times, and then if that doesn't help, then we tell, you cannot make that referral. So right now what we are doing is that we have the employers counseling. We have our own staff here that we don't want to overburden. We only send the very bad cases to them. Then we are now increasing our own time of also playing some roles. And then the third part is that we also have some private, now we actually go to the extent of also telling the patients sometimes about some private counselors. For example, I have some patients who've come in here, told me that they have counselors online from the US, they like it, right? So we also educate them about that, about even endorsing quick and things like that. But there's still an ongoing discussion because it's just like Chris said, yeah, we still have some challenges there, but we hope, we had a meeting, we discussed it last Thursday. We hope that we'll keep working on that until we get, we get to where we actually want to get to, yeah.
Councillor Noxena.
Is there any chance of our region getting nasal flu spray, like the nasal flu vaccine for children again? There's been a few years now where we haven't been able to get it. And I just see it as it's an easy way to get our kids a flu vaccine.
Yeah, I know that Northern Health did receive some of the nasal, not enough to do the number of children. But I don't believe that we received any in the Northeast. It wasn't a big volume. I can look into that and follow up in terms of what is the provincial plan and how many of doses are available and what the logistics are for the distribution of those.
Councillor Norbury.
Thank you, Mayor Kukalka. Simple, direct question. Are you finding any issues with childcare for your staff?
I think we were struggling when the program closed down in the summer. My understanding is that most of the staff have been able to find some type of a solution in the community, but I haven't specifically talked to every single staff member about this.
Councillor Hoffman.
I think one of the benefits is that we were, this came to our attention and Melanie was quite concerned about a number of her staff, and we were able to then connect with YMCA, who's doing quite a bit of work across the Northeast. And then they were able to make that connection with the childcare provider to try to support them, at least starting out with the after-school program and then determining if they could restart up the childcare services. So, and we know that the district of Tumbler Ridge was very instrumental in that as well, in terms of trying to figure out what were the challenges of that childcare provider, and was it space and was it rent and those types of things. So we really thank you for that.
Councillor Hoffman.
Thank you. So not easy and not straightforward, but something you said earlier stuck in my mind, that you had recruits that have a whole lot of options, and that's great for them. I'm very happy for them. But with the attrition rates over the last couple of years with COVID and an uncertain future, not just for Northern Health, is there talk on some level of increasing enrollments for, well, replacements across the board, nurses, support staff, everything? Or are we just going to be facing this shortage of manpower for the foreseeable future?
Yeah, so I can speak to that. So this has become, as you're aware, both a provincial and a national concern, and that has escalated even more so in the last 6 months to a year. The province does have a provincial health human resource plan that has resulted in a number of healthcare schools or programs increasing enrollments, both in terms of physicians. There's a brand new program, I believe, starting in Surrey, and slowly increasing some of the class sizes in other medical programs, as well as Northern Lights College and Dawson Creek. They've increased to 2 programs a year for home support workers, as well as through the provincially funded, it's like an apprentice program. It's called the HCAP. It's the Healthcare Aid or the Healthcare Assistant Program, where they do work in, we hire them as employees, they work for us, and then they take a portion of their school, they come back and they work in that area, and then they go and complete the rest of that 4-month or the 8-month program. And that has led to filling a lot of the health support worker positions, both in long-term care as well as community. They now, Northern Lights College has received funding to look at bridging from those home support workers to licensed practical nurses. And so they will be graduating more of the licensed practical nurses to fill that. We are now into the 2nd year of the Northeast RN program that is being offered by UNBC out of the Fort St. John campus. We're also working in terms of identifying increasing seats for X-ray techs and lab through the Prince George program. So and the other big initiative that Northern Health is leading the province in is internationally trained or educated healthcare professionals. So that includes physicians. So the government, I think they had 35 graduates from what's called a PRA, or a Practice Readiness Assessment Program, of which Tumbler Ridge has a number of them. And now they're, I think starting in the new year, they've increased that to 90, like they're tripling in terms of how many physicians that will be able to go through that program to then go out into the community. They're working with nurses that are internationally educated so that we can shorten their time and the process for their review of their knowledge and their credentialing to be able to hire them, similar to dental hygienists and pharmacy techs. So there's quite a large strategy to slowly and incrementally, and then in some respects being able to quickly ramp up the healthcare workforce to meet the needs that are out there and the future needs.
Okay, I want to add to that. There's something I think I and my colleagues as well, we are trying to work out something as well. Part of the reason why sometimes we have challenges in Tumbler Ridge is that we also notice that some of the doctors, in the cities, they really don't know they don't really understand the healthcare here in Tumbler Ridge. Sometimes they call you and you tell them that you can't do this. They're like, you mean you can't do this in Tumbler Ridge? They really don't understand. So what we are trying to do now is that we are working around bringing the residence program in Tumbler Ridge. We are hoping that we've applied. We've given them all the information that they want. We are hoping that from June next year, the first intake will come. Yeah, that means that by residency, I mean doctors in training coming here, passing through Tumbler Ridge. Because when I came in here, we had some doctors who eventually worked in Tumbler Ridge for some time under Charles Helm, and they are now in Dawson Creek in Fort St. John. These are people in the city, but because they passed through the very rural setting like Tumbler Ridge, they became used to it and they actually liked it. We've had medical students who came down. I think there was a medical student who came here sometime last year. He wrote a beautiful article on Tumbler Ridge in the papers, right? And immediately he wrote that article. I think that same, I think it was this year. So sometime he wrote it sometime early this year. We had like 3 students who just came into Tumbler Ridge this same year after that article, So what we are trying to do now, we want to start a residency program where they can be anywhere, but they have postings in Tumbler Ridge so that they can see, they can talk about it, and then who knows, That way there will be interest. And that way we also want a situation where there will never be a lack of doctors around, because residents are actually doctors, right? So we have more doctors in the community and things like that. Then the second thing I wanted to talk about was, I also hope that maybe sometime next year, we can also, just like Melanie and Angela has said, we are, I think I'm actually geared to trying to groom people in the community, right? So maybe sometime next year we hope to get the school children involved. I hope to go to schools and talk about, bring them here like we did sometime 2 years ago before the COVID. Talk to them about career. Talk to them about medical. The things that they can actually find in medical fields. Bring them to the nurse. Take them around. Do hospital. Walk around and try to create some interest there. Who knows? Some of them might eventually go. I think I've seen 1 or 2 persons in this town who've gone. I think one of them is a doc. It's training also. People like that are likely to come back. People like that are likely to stay because this is home for them. So we hope that next year we can actually start, talking to them at least, and then watch how things turn out. Yeah, thank you.
Councillor Hoffman, any follow-up?
No, just thank you. I appreciate that detail.
Sorry. All right, well, thank you very much. I have a few things. One you mentioned in regards to one of the nurses being off on maternity leave soon, and sounds like you have a backfill. Do you foresee any shortages through the holiday season in regards to staffing / diversions?
No, at this point, we have the holiday season covered. Again, notwithstanding if people got sick, but we have everything covered.
Okay, I totally appreciate that. I also appreciate, Melanie, when you reach out and give, whether it's myself or staff, the heads up. You're going to have 2 new people on the health task force. Just in regards to the diversion, gives us a chance. Maybe there's, obviously something we can do, or at least get it properly advertised. So I appreciate the heads up. I guess the other question I'd have is, you'd mentioned earlier in regards to doctor appointments, it's usually 1 to 2 weeks. Are we seeing a longer span in Tumbler Ridge right now? Like, I'm hearing from residents up to 4 weeks to get into a doctor's appointment. Is that true?
I'm going to ask Dr. Iffy if he could maybe address this first, and then I'll put my 2 cents in after.
Yeah, there have been a relative increase in the number of appointments and all that. Yes, and the wait time is slightly long, but there are actually a couple of reasons why that is the case. For example, number one, we actually see a lot of new presence in the community right now. I've seen a lot of people I've never met before, right? And like I said, we are looking for other ways to address that. For example, most of our updates, we try to bring those guys in, to actually see how we can actually reduce that. But yes, averagely it has. But we keep talking, and then we'll keep discussing among ourselves and seeing how we can actually reduce that to a relatively good point. Let me put it that way.
And my comment to this is, and thank you for that, Dr. Iffy. My comment is that, when we have a physician who leaves the community in the sense that they are on vacation, we are then down to 2 physicians who then cover the emerge 1 day each. And as Dr. Iffy mentioned, usually the post call, especially if the evening was particularly busy, they then don't see people the next day. And so when we have those challenges, that's generally when we start to see a bit of a lengthening of the availability to come see physicians, because number one, there's one physician completely out of the community who isn't seeing patients for a week or 2 while they're on vacation. And then with the post call, we're reducing the amount of appointments that the other 2 can see. And so again, I think part of the increase within the 0.5 new FTE for the physician that's coming to the community will be to hopefully help in having someone in the community who can help fill that gap, so to speak. And so that's part of what we're trying to do to, again, reduce those wait times. Does that help?
It does, and I appreciate that. And I assume that's what it was, but it's nice to get the answer. Obviously, we Zoom our meetings, so I know residents have that question. They ask it daily. And I'm just wondering if that's why we're seeing and I think it was Councilor O'Berry mentioned earlier, the bump up in after call at Emerge. Is people are waiting, they think they're waiting too long for a doctor's appointment, so they go into Emerge.
No.
Because Emerge is available, right? I can go to Emerge at any time.
No. Some of them is because, like I said initially, some of them is because of that, but most of them not necessarily. For example, I think we had a meeting about 2 weeks ago. What we now do is that not every lab, for example, when we see a patient and we order some lab work, we don't normally after the lab, when we review the lab work, when the result is out, we normally ask to record the patient so that we can discuss that. But these days we do it there and then. For example, every day I go through my lab to see exactly the results. Once I see a lab that is concerning, I will put the patient on the schedule. I will call the patient that day. So I don't have to, the person doesn't have to wait for 2 or 3 days, because waiting will actually block some other people. So I do it there and then. So all these are just a way of, seeing how we can actually work around cutting down on the wait time and all that. Yeah. So let me put it out here.
Okay, appreciate that. So Councilor Barry mentioned it earlier in regards to BCHS. And when I see the concern in here when we have a nurse staying over in a diagnostic treatment center, so it's either diagnose and release or treat and transfer, and we have nurses having to stay over because it's a yellow transfer, I think that's something we can work from our side when we have a delegation from BC Ambulance. And I think that'll be something we bring up to see if there's another way of working around that. I know we sent a support letter to try and add a different shift in Tumbler Ridge instead of an SOC going to an Alpha or a Bravo car. So I think that'll be pushed from council side too. But thanks to the nurses that are sleeping over at the clinic, and that's tough. I used to work as a paramedic over there, and I know we had to spend some nights in the clinic due to weather. But when it's not weather related, it's tough. And I mean, it's definitely not the paramedics locally. I mean, they're just following their employer's decisions. So I definitely want to make sure that's known. And I've talked to a lot of our attendants and paramedics and stuff here in town, and their hands are tied on the transfers. But that's something we can work from our angle. The other thing I want to mention is the Northern Health travel pool. Hats off to you. Because I go over to the clinic, not all the time, but when I have a pass to hand out, so I get to meet and talk to the new nurses or that come into our community. And there's been some great discussions with all your staff over there. There were maybe two or three nurses in Emerge at the same time, and they just love it. To be able to add themselves to that pool now and take regular shifts in Tumbler. I've talked to a lot of them. They're pretty excited about that and how Northern Health opened that option up instead of them having to stay with an agency nursing recruitment center. So hats off to Northern Health to do that. And I think it's hats off to these nurses that are willing to take regular shifts in Tumbler Ridge, because eventually they're going to love it like the rest of us do, and they're going to move to our town. So we know that's going to happen. And that's the other thing. I know council's well aware of it, but we give out passes to all the nurses, all medical professionals, so X-ray lab, the nurses, the doctors. And again, that's just our appreciation back to you guys for coming up and working in Tumbler Ridge and taking care of our residents. So I want to thank you for that part. Any more questions from council? Cool. Okay, I think that's it. So thank you very much again for joining us. Glad you can make it via Zoom. Maybe next time it'll be in person. And Merry Christmas to you and your family, and safe holidays.
Yep,
Thank you
thanks
so
for
much.
having us. Great questions. Take care.
Yeah. Thanks a lot.
Thank you very much, Dr. Iffy. Question and answer period. Chief Curry, did you receive anything via email? Okay. Take adjournment. Councilor Norbury.
That we adjourn the December 20th, 2022 regular special meeting of council.
Seconder. Councilor Julik, all in favor? Carried.